So once you have, the initial step is once you've got your DICOM stack, you'll be presented with a folder with a list of images in, and if you can simply load up the image by dragging and dropping onto ITK Snap, and then you click Load as Main Image. If you have two phases available, so sometimes you'll be fortunate and have both arterial and portovenous phase imaging, you can load a second image with the Load Additional Image option. You should load, I would suggest that you do the segmentation of the portovenous phase and use the arterial phase as a reference if both are available, and you should load the portovenous phase first, because when you go to save the image, it will only save the main image and you can't save the additional image. So only use the additional image function to load the arterial phase if available. So once you've loaded your image, you'll be presented with this. And I would suggest the initial step is you navigate to the layer inspector. And if you click on it, you will then be presented with this contrast option. And I will typically set my level to 100. And my window to 500, and that's usually suitable for the majority of cases. Here we've got some arterial phase imaging for this case, so the arteries should be relatively easy to do, but the veins may be slightly more challenging. When you're I would say that when you're trying to segment the colon, it can sometimes be slightly difficult to identify. So in that situation, I will frequently turn the window to 800, which I find sometimes is useful in differentiating colon from the surrounding abdominal fat, as sometimes the actual border can be somewhat indistinct. But we'll go back to 500 in the initial instance. The next step will be to import your labels. So you can navigate up to segmentation and then go to the import label description option, and then just navigate towards wherever you have placed that file. So for me, it's in the Dropbox. For you, it'll be in our shared Dropbox file. And then you will see that you have, instead of labels 1, 2, 3, 4, 5, you have a range of labels with the appropriate anatomical name. So whichever structure you're segmenting, you would just select that as your brush. So we'll start with the arteries. The main tool you will use during the segmentation process is the paintbrush tool. So that's where you basically have the option to essentially draw on the screen, which I'm sure is very straightforward, and I'm sure you've all figured out how to do that. There are a few little tips and tricks that I can suggest. The main one being that if you've got a long tubular structure which is passing vertically through the abdomen, it would be reasonable to use the 3D brush option. As I'll show you the difference. So if we take 3D off and I paint on one layer and update, we have, and if we zoom into this, we've got one slice thickness. However, if I click the 3D option and redraw over the same area, you'll notice that multiple layers have been done, because the 3D brush is treating your paintbrush as if it's a complete sphere. So it is quicker to segment using this technique. If you're fortunate enough to have an arterial phase available, you could try and segment at least the arteries using the algorithmic methods available. So we'll walk through that. So you'll notice that there's an icon that's called the active contour, aka the snake tool. So if you click on that, you'll then be presented with a bounding box which you should resize. So this is basically establishing the area for which of the imaging which the algorithm will take into account. And if you zoom to fit the other boxes, you can dramatically reduce that. I would say that, I mean, I'm quite fortunate in that I have quite a high-powered PC, so I could do this without reducing the volume down. However, if you're working with a lower performance laptop or lower performance PC, it's worthwhile reducing the amount of data the computer has to process. So click the resample region of interest. So the ROI stands for region of interest. So that's essentially stating that you're taking a subsample of the imaging. And the other thing I would suggest doing, which isn't relevant here, but is relevant if you've already added segmentations, and is a useful thing to have throughout the segmentation processes, you'll notice that there's two options in the segmentation labels box. So there's the active label, and then there's the paint over label. So with the paint over label, you can scroll up to the option of all labels. So if you have the all labels button clicked, that means that whatever you segment it will paint over, even if you've added a label previously. But if you add the clear label section, it will only segment areas without an existing label. So it means that you won't ruin, if you spent a long time segmenting some of the smaller, more peripheral vessels, you won't ruin them by adding an additional label which would erase some of that finer work. So I would suggest that you have this on clear label at most times. You can also change this to be other structures. So say you've erroneously labeled something, or you want to rapidly change something or rapidly relabel something, you can kind of stipulate that you'll only draw over an existing label with a new label. So say you've added well, let's show an example. So let's say if we go back to the paintbrush tool, say if I have added a red tool, and let's state that I'm only going to draw over the arterial label with vein. If I draw in here with the venous label, it's not doing anything until I get to the artery. So it's just an easy way of limiting your segmentation to something that you would want. You may find that a useful tool at certain points, but let's go back to the region of interest. So let's set ourselves up. So we want to label an artery, and we want to only do it over the clear labels. So then you go to the segment, click OK. And the basic principle of this method is that you are setting thresholds, which is essentially act as a mask. So it's a seed-based growing approach in which you'll basically add points on the scan, and then everything. The basic principle is that the algorithm will iteratively add any additional voxels that are near to the parameters you've set. So this will make more sense once we show it in action. So what we're trying to do is we want to mask out. So anything in blue is not going to get segmented. It's essentially like if you ever use Photoshop, it's essentially a mask which is blocking it out. So in this situation, what we're wanting to achieve is to isolate the arterial structures. So you can see that there's probably going to be a problem here in that the arteries aren't fully isolated from some of the structures, so we need to up the lower threshold to try and isolate these, because the way that this works, so I think we've isolated these enough for now. And if we go to the next section, we're then going to add bubbles. So if you want to click on an area and click add bubble, and then reduce it down so the bubble is within the area that you're of interest. There's a slightly odd bug in the system whereby you can adjust the size, but don't click delete active bubble, as it will crash the program. I would also advise that if you've done a lot of existing segmentation already, so the classic example is you've done all the vessels on a CTC and then you're going to automatically segment the colon using this method, definitely save it before you do so, because there's a number of times where this has crashed and I've lost an hour and a half's worth of work. So that can be quite frustrating. So if you're doing this after having done existing segmentations on other structures, definitely save beforehand. So just scroll through the image and then you can just add the bubbles as we go down. And we can go down, we need to go down, we're going up there. So what you're doing here is basically setting points for which the algorithm, these act as seeds which the segmentation grows from. And the way the algorithm works is you've basically set parameters which state that you're only interested in voxels which have these Hounsfield intensity characteristics. So when you've got something like an arterial scan where you've got very bright white arterial vessels, it's quite easy to label those as they're well isolated from the surrounding structures, or certainly more so than if you had, say, portovenous imaging. And you may need to reduce these. The more labels you add, the more intense this is going to be on your computer. So again, if you've got a lower performance PC, this may not necessarily work as well as you might hope. Okay, so once we've set a bunch of things, we can kind of go to the update option. And the other thing you can do is set this to continuous, as it will better illustrate what we're going to subsequently do. So then go to next. And you'll notice that we've got these balls here which serve as our seeds. And if you watch the screen, you're going to notice that these areas in red start growing into these vessels. So if we click play, so that's probably as good as we're going to get. But I think using this approach is going to be certainly quicker if you can achieve it, and the results are going to be better from an aesthetic point of view, because you don't get as severe stepping artifact between each slice, because the computer is probably better at overlapping those edges. So you can see that the result from this is smoother than in comparison to, say, the previous case where we went through. So once you're done, you can just click finish, and you'll notice now we have certainly the aorta and a degree of the SMA renal vessels and celiac plexus segmented. So this is a good start. We can now move to the kind of more traditional way of doing things, in which we'll use the brush tool. And we'll take 3D off. And now we can just have a quick look at this scan. And see what we can see. So let's go back to the top. So we'll start with the Amigo method, in which we're starting with the aorta, and we've identified the celiac trunk first. And then here we are with the SMA emerging as the second major vessel that comes off anteriorly off the aorta. And we can track this down. And here it's relative with an arterial scan. It's very easy to see this middle colic artery, which is coming off anteriorly, passing forward up to here, whereby it is. So I think there's probably a little proximal branch coming off here, which you can just about make out, which is going to pass towards the left colon. But the main vessel here is coursing forward, passing over the SMV, and then we can follow this as it courses up towards the hepatic flexure and round. So that would be the typical configuration. So let's go back up to where the origin, and we notice that we've got these jejunal branches coming out laterally, and a larger one here, and here we're observing the aleocolic artery in all likelihood passing posteriorly with respect to the SMV, and then coursing laterally, which we can follow. And there's probably a little bit of a bifurcation here. So this will be this then bifurcates. This will continue probably to the right colon as a what would be ostensibly called a right colic artery, although in our naming schema we don't name it as such, because if we're taking the vessel centrally, we in theory should not encounter this bifurcation. And the lower vessel here is coursing down towards cecum. So we know that this is the aleocolic artery, and then we can also identify the accompanying vein, which is frequently sort of larger and certainly will be a different Hounsfield intensity on this arterial scan. And we can follow this back up where we would expect it to insert into SMV, which it likely does here. If we follow the SMV down, this will eventually let's go back up. There's something a little bit odd there. So we've got SMV. This is coursing downwards. Oh, I've gone wrong there. So the aleocolic artery is passing out anteriorly with respect to SMV, and the aleocolic vein is here with the SMV here. So I was a little bit too far lateral with my initial assessment. So I think what's interesting here is the SMA probably bifurcates early into two separate vessels. In any case, we've identified the aleocolic vein, which is inserting into its typical location into the SMV, and I suspect in this arterial scan, the central veins are going to be slightly more tricky. Which they are, and this is going to be a difficult interpretation. So I think you've got a middle colic vein coming out here, which is in passing anteriorly. And I think it's sometimes helpful to, when you do have a difficult scan, you can kind of grasp towards landmarks that you already know are correct. So we know that the middle colic artery is here, which means that the accompanying vessel by a lot is likely going to be the MCV. And it's certainly coming out in the position you would expect. So the MCV, when it is present and draining into the SMV, usually drains off the anterior aspect, as opposed to Henle's, which you'll frequently find passing out, if this is a clock face, passing into the sort of 9 o'clock, between sort of 10 and 8 o'clock, but typically kind of coming off more laterally towards the right. And I suspect that this is Henle's here, although it is extremely unclear. If we follow one of these vessels. So again, I think this is where it is useful to try and grasp things which are more evident. So we know that the GEV is going to be coursing along the stomach, which we can visualize here. And we can see that there's a vessel that's running along the lower aspect, or the greater curvature of the stomach. So this is likely going to be GEV. And you can probably differentiate. There's two vessels here. So the smaller, more intense vessel is going to be the artery, because we know we've got an arterial phase. But also the veins in general are going to be larger. And we can follow this going back. And this is eventually going to probably insert into Henle's here. There's likely something going, so that you can see there's just like a slight movement, and it's all very it's very difficult here because you've got no portovenous contrast. So whilst the arteries do make the arterial segmentation easier, they make the venous segmentation much, much harder, which is why I typically prefer the portovenous phase. But we sometimes do not have the luxury of a choice. I was quite zoomed in to this image, and actually in this situation it's probably making things a little harder. So sometimes there is value in zooming out, as it sometimes adds a little bit of clarity, certainly if you've got all the kind of the structures blending into one, because they're all essentially the same shade of grey. Another useful tip or anatomical finding is that you will frequently see the right branch of the middle colic artery passing towards the hepatic flexure, and that can also be useful in identifying an accompanying vein, which in this situation would be the SRCV in all likelihood. So I think that there's a GV. I think there's an SRCV. I think that there is very likely a small little pancreatic branch. But in all honesty, I think that the constituent vessels of Henle's in this situation will be GEV, SRCV, and ASPDV, which would be that would be the typical configuration that you would expect. But this is quite a tricky case. So now we can just move on to getting on with the segmentation, which sometimes will be useful in differentiating some of those more tricky vessels. And I find that that the ease of your interpretation is going to be eased by the process of just doing the segmentation, because I think it's far easier to start identifying structures when you're actually doing the segmentation. And you also have the luxury that you don't have if you're trying to configure this in your head or figure out what's going on purely mentally, is that, you know, you can flick back to, if you click all these icons let you enlarge a certain area. So if you click on A, this will make the axial view occupy the entire screen. If you use the sagittal, that would increase the sagittal. But you also have the luxury of seeing how this is all emerging, and you can kind of start to see if things will. You'll get a sense of like one. The first question you can ask yourself is this anatomically possible, yes or no? And then you'll also get a sense of what looks right based on your experience of doing multiple cases, but also seeing the operative findings. If you're seeing something that's like extremely unusual or doesn't look right, so for example, if you have a vessel which kind of bifurcates off and then goes and inserts into the same vessel down the road, chances are you've gone wrong. So I think like looking at the segmentation as you go, if you're struggling, is going to be very useful in helping you differentiate the different vessels in these more difficult cases. But I mean, a lot of it is just experience, and you will kind of, you know, you will build as you increase the number of cases you do, you'll get better and better at this. But a case like this at the start is going to be tricky, and you're going to get a little bit probably cross-eyed trying to figure out what's actually going on. So I'll just crack on with segmenting this case, and we can see the result as we go. But this is, you know, this is certainly one of the more challenging cases that we encounter in terms of the actual interpretation, and it'll probably be not until you're getting to sort of 50, 60 segmentations under your belt where you're going to be able to tease this out. And even now, occasionally I'll need my kind of consultant GI radiologist who's experienced in looking at these kind of structures to help and ensure that the model is accurate. But that's why we've got this kind of like structured hierarchy in terms of like our team, so I can look at it, and then if I'm struggling, I can get someone else to take a look. I think trying to follow the vessels out to their terminal destination is quite useful. I kind of went back and forth with this. Initially, we tried to do it, and then we moved away from it. And what we found is that certainly for the venous vessels, if you can't see where they're kind of terminating, it can be difficult in terms of differentiating what vessels what. Certainly for people who are not familiar with the anatomy, I think some of the more experienced practitioners who are used to seeing this anatomy intraoperatively will get a better sense of what vessels would represent what based on where they're kind of inserting into the SMV or Henle. But certainly people who are just starting out in this operation will probably struggle to differentiate, say, a middle colloid from an SRCV, etc., if you don't include where the vessels actually terminate. You'll notice here, as you go down, you'll start to see the IM the IMA emerging off as the kind of third major anterior, the third major ventral branch that comes off on the abdominal aorta. This isn't relevant particularly for the right colic cases, but some of the surgeons do like us to add it in and try to show the kind of full blood supply around the splenic flexure. So the IMA will emerge off. There are branching patterns that vary, but typically you will see a trifurcation into sigmoid, superior rectal artery, which kind of courses down to provide the blood supply to the upper rectum, and an ascending or left colic branch which passes upward towards the splenic flexure and should, in theory, through the marginal artery. And here we go. So we've got a bifurcation now. These will likely be sigmoid branches, and then this will kind of pass down, and you can usually follow this branch all the way down into the rectum. So it'll go over the common iliac arteries, which you see here, and then start descending into the pelvis to supply the rectum. And frequently what you'll see is that this vessel bifurcates into two kind of terminal branches which run down the kind of lateral, the posterior lateral, left and right lateral aspects of in the mesorectal fascia, which again, not relevant for these right-sided colonic cases, but is a useful point to know just for kind of your general anatomical knowledge, which is a big advantage of doing this kind of work, in that your anatomy and your ability to kind of interpret CT scans for anatomical variations, which would not typically be included in the average radiology report, is significantly enhanced, because there's a fundamental difference between the scan report, which emphasizes the staging of the tumor, but we're also interested in the anatomical variations from a technical aspect. So this really bridges the gap between radiology and surgery. And here we see this little branch here is going to be the ascending left colic artery, which frequently will run in parallel to this vessel here, which would be the inferior. So here we notice that the vein is moving laterally, and it's coursing around. The artery is moving laterally, and then sort of and then we can check on our progress and see that this is the classic trifurcation that you see with sigmoid, superior rectal artery, and the ascending left colic branch, and that would be the classic. And this is quite a long IMA, which is relevant if you're performing a left-sided resection or any form of resection of the rectum. So if we get back to the area that we're more interested in, which is the colonic blood supply. Sometimes when the vessels are particularly thin, it can be useful to slightly over-segment what you're seeing, because you've got to imagine that you've got to anticipate that the if we go back to the actual 3D view, these vessels are going to undergo a degree of post-processing when they're uploaded to the platform. So when you have very thin areas like this, sometimes that smoothing process can degrade the integrity of the mesh, so you ended up with this kind of like dotted line artifact. And you can counter that where you have particularly thin vessels by just slightly over segmenting beyond the bounds of what you actually see on the scan, because then you know that when the subsequent decimation and smoothing occurs, it's not going to degrade the integrity of your mesh. And we'll just follow this middle colic artery as far as we can take it. And it's certainly useful in these sorts of scans where it is particularly difficult to segment the arteries as far as you can, because then you've almost eliminated one of the potential confounders that you may misidentify as it passes along its course. Because even on an arterial scan, you'll notice that as we move more peripherally, it becomes the actual degree of contrast starts to fade. So it is useful in these situations to identify. So what we've seen here is, in this case, we have a single middle colic artery trunk, which then passes out and bifurcates into the classic left and right middle colic artery configuration. So the right passes, as you'd expect, towards the right colon to supply the usually passes aiming toward the right branch. Usually kind of passes in a direction towards the hepatic flexure, and then will subsequently form part of the marginal artery, which supplies the blood supply to the majority of the colon. And the left will kind of pass towards some point along the transverse colon before again joining with that marginal artery to supply the colon along its entire length. Follow this. Where is this going? So I think you've actually got a kind of trifurcation. So this that little artery here, you can follow it as it kind of courses back towards here, which is all part. So this will be a kind of more left-sided branch. As a general tip, when you're doing these smaller vessels, sometimes you'll follow them and then they'll start to disappear. Scrolling up and down can sometimes help you identify these as they course along their entire length. Because if you have a tortuous course with the artery going kind of in like this through space, moving up or down will help you identify that sort of more tortuous course. So we follow this as it goes down. And then it's going to start moving across. Just see, it's all very subtle. It's all really subtle. I mean, without the arterial phase here, you would have no chance of identifying these sorts of little peripheral branches. And to be honest, I mean, they're not actually. They may not be that relevant intraoperatively, but I think it's certainly better to try. If you can identify them, brilliant. You may not be able to identify these across their entire length. Certainly if you've got a patient like this who's quite skinny, and skinny patients are paradoxically harder to interpret on the imaging because of the paucity of intra-abdominal fat that helps you differentiate. You want quite a fatty mesentery, ideally, because it is much easier to help identify the vessels. If you've got a paucity of intra-abdominal fat, the vessels are kind of stacked on top of each other, and you don't have intra-abdominal fat enhances differently. So you can see here that it's this sort of like nice dark grey colour, which can really help in terms of differentiating from, say, pancreas and duodenum, along with the intra-abdominal mesenteric vessels. So in that situation, it can make the interpretation difficult. And I would say that actually, in comparison to, say, the UK patients, anecdotally, I would say that the Dutch patients are usually slightly on the thinner side, comparatively. So I don't know if the Dutch scans are slightly harder to interpret in comparison to our UK patients, but okay, so I think we've made some good progress now with the arterial system, and we have. So this would be, I mean, this would be fairly classic. You've got the short arterial trunk here. You've got the bifurcation into this left branch, which is passing towards the distal transverse colon. And then you've got this secondary branch, which then bifurcates into a branch which is supplying the hepatic flexure and the more proximal transverse colon. And I think when we have these sorts of, certainly when we have this sort of configuration, it is important to identify, because oftentimes, you could easily misidentify this bifurcation for the actual, because if you're doing a right hemicolectomy, you're really wanting to take the vessels here rather than here, which would be all too easy to do when you have these secondary branching points. So I think now we can try and get some of our venous structures in place. I recognize here that we have a gap, but I think let's see if we can kind of identify where that's occurring. That's what I'm talking about, where you can kind of it's useful to kind of see the vessel segmentation in relation to the actual model you're producing, and just thickening up these some more delicate peripheral branches. Okay, I think we've probably done enough now on the arterial vessels for the time being. We can probably go back and just add in some of these celiac ones, especially within arterial segmentation, where this is actually quite easy to do because they're very well enhancing. So here on the this is the common hepatic artery, and then that bifurcates into the proper hepatic, and then at the gastroduodenal artery comes off that and passes inferiorly over the head of the pancreas behind the duodenum to eventually merge here. It disappears somewhat in this parenchyma, but oftentimes if you can kind of scroll up and down and identify things as they come out a bit clearer, it can help you identify the appropriate vessel and then follow it along its course. And I think in this situation, adding this in will be useful, as it will help you identify the subsequent GV, and also it eliminates another potential vessel which you can readily identify, but if you left just peripherally unsegmented may confuse you, and you may kind of misidentify or mislabel it as something down the line, certainly when you're more kind of inexperienced and just kind of learning about building your kind of case experience. So here we go. Right, let's start with some of the veins. So I think in this situation, retreat back up to where it's nice and easy, and then you can get your eye in. I would say that in these sorts of cases where the veins aren't well established, there may be a degree to which you have to interpret the imaging with a degree of kind of creativity in terms of outlining the specific borders of the SMV. I find on the arterial scans it can be very difficult to kind of differentiate the actual kind of the boundaries of the SMV as it courses through the pancreatic tissue. these models are essentially producing a schematic of the actual anatomy. So oftentimes, I wouldn't say actually it's getting the configuration of the vessels right, rather than getting too hung up on the absolute boundaries of them, because that isn't as important as ensuring that the model represents an anatomical truth rather than the absolute, vessel caliber and width and shape. It's making sure that they insert in the right place, and it's making sure that you've got the correct vessel configuration. So far, so good. But here, if you were trying to, it's easier if you follow these things going down from the portal vein, and it just makes everything a little bit easier in terms of identifying identifying the SMV as it kind of courses downwards. And you see here we've got the MCV, which we'll kind of deal with later. I would say for now, let's just stick with our major thing. And you'll notice here there's a vessel coming out, and then this would represent what I would call the first jejunal vein, which looks like it's passing inferiorly with respect to the middle colic artery. And here we're seeing the aleocolic vein emerge from the SMV. So you can follow this down a little bit more, and you can see that this is starting to bifurcate. Oftentimes you can kind of see the terminal portion of the SMV kind of terminates into 3 terminal branches which drain the ileum. Very occasionally, you may see that the aleocolic vein inserts into one of these terminal ileal branches, as opposed to the typical draining location of the SMV. But for the operating surgeon, it's probably irrelevant, as you probably would not necessarily be able to differentiate unless you kind of exposed all the veins quite medially as well as laterally in the mesentery. You wouldn't probably see that this was a kind of terminal branch. It's just maybe important to. It's more of a naming issue if we were trying to say assess someone's ability to interpret the anatomy, as opposed to say something that's that clinically relevant. But it potentially could be, because you'd want to know. It would potentially help you identify this vessel intraoperatively. Let's see what's going on here. Okay, so this is going to be the aleocolic vein, and then these are more kind of terminal branches which correspond to, this is going to be Caspilium mothececum, and then this is going to be a kind of right colic branch, if you will. But because the surgeons will be operating on SMV, and here, all this is largely irrelevant, other than the fact that it's useful for you to identify for your own learning, but also ensuring that you've identified the ileocolic vein, as opposed to one of the instead of misidentifying a right colic artery and vein and missing the ileocolic. Let's go back up, and you can see here this jejunal vein, this big fat jejunal vein that's coming out proximal to the origin of the MCA. This is useful in terms of, one, not damaging this vessel during the dissection, but also it will help the operating surgeons identify the origin of the MCA with respect. So the surgeons will be looking at this sort of view, and they'll be dissecting on the anterior aspect of the SMV, and then once they encounter this, they know that the MCA is going to be lurking just above it. So it can really help with intraoperative. Having that model and having that information means that the operating surgeon can be more confident in their intraoperative decision making, and it really helps with the dissection in terms of the speed at which they're able to identify structures intraoperatively, and their confidence of what they're looking at intraoperatively is indeed the structure they think it is. And these are kind of subtle things that are difficult to quantify or measure, or certainly haven't been proven quantitatively yet, but certainly subjectively that is what the surgeons using these sorts of models are finding. Oops. Right, so let's get to the difficult part now, which is going to be identifying the structures of Henle's. So I think I'll probably start with something that's relatively easy, which is going to be the GEV, because this is going to be the most readily identifiable vessel that we have here. We'll follow this down, going. So that's the classic configuration. You see, it kind of does this hairpin turn, where it's running lateral and to the right before doing a hairpin turn, and then running medially to drain back into Henle's. And that will be the classic thing you'll see for GEV, and is a really useful means of helping identify that vessel when you're starting out. So all this is where it all becomes very indistinct, but one would suspect this is going to be Henle's here, because it's certainly the right approximate area. So this is where sometimes it's useful to take away so I don't know if you'll believe me or whether you can kind of make this out, but you've got SMV here, and then as you'll just see, look, it's this MCV that's coming off anteriorly and then passing to the right. And we can kind of make an educated guess that this is indeed MCV, because it is running along with the artery, which is what you'd expect anatomically. So sometimes when the imaging is difficult, you can combine some of it's experience, but some of it is also using what you know to be your underlying understanding of anatomy can really help you differentiate what these things are if you're struggling, because you know that the typical configuration will be that the MCA and the MCV will run along with each other, as the arterial and venous vessels are often paired. Not always, but oftentimes. So it really helps us in these sorts of tricky cases. We can use our understanding of anatomy to help us identify what's going on. So something looks to be bifurcating here to me. You've got one vessel here which is running along with the artery. And this is, again, it is corresponding to the arterial blood supply. So you can kind of be more confident if something looks right, it probably is going to be right. It's when things start looking weird, or you start seeing weird configurations that you've never seen before or haven't anatomically been described in certain situations. That's when you really need to question whether what you think you're looking at is actually what you're looking at. But even when it's subtle like this, if you're following if you've got the arteries already in and you're confident of them, then you can be also confident that the venous blood supply will somewhat mirror the arterial blood supply. And it is in this situation. And what can be difficult at the start when this is one of the things, this has become somewhat easier as the segmentation's gone on, because you're seeing the anatomy emerge in the 3D, and it does really help. So like if you're trying to think of what people are doing in terms of trying to interpret this image and get a mental conception in their head, even if using the Amigo method, if you're not going through this process of manual segmentation and looking at the vessels and analyzing them in a very detailed fashion, I think it is much more difficult to kind of get that mental conception in your mind. Even if you're very experienced. And I think we did probably get the right interpretation off the bat, but it was certainly more difficult than it is now, because we've got the arteries already in. It's easier to follow vessels when you've sort of eliminated the other possibilities. So you do have that advantage, and I think it's a big one when you're starting out. So we can update this now. And this is looking pretty good, I would say. So this is probably Henley's, and then you've got this middle colic vessel, which is coming off anatomically in approximately the right place. What I would say is, in this situation, if you've got this lone MCA branch here, which isn't got anything accompanying it, I'd say be cautious in that situation. Although it isn't necessarily absolutely relevant for the case, there may be an accompanying vein which drains along with it, and it does. So here we have another likely MCV branch, which is accompanying this vessel that is inserting laterally into the SMV, and is corresponding again. It's accompanying the arteries. And again, I don't know if you can kind of make this out. It's all very subtle, but that looks right. It looks like a proper vessel, and it's in an area which anatomically makes sense. So you can kind of be confident that your assessment is correct in that situation. This is just like, in the operation, if you're doing a standard right hemicolectomy, this isn't relevant. However, if you were doing a more extended dissection, this may be more relevant in that situation. So in this situation, you've got one MCA trunk, but you've also got two separate MCV trunks, in that this vessel is accompanying this vessel, which is going to be supplying the distal transverse colon. Again, the naming conventions here may vary, and it's if this vessel was to pass towards the descending colon, and so in a similar fashion to how there are essentially no anatomical or radiological definitions of what constitutes the hepatic or splenic flexures. So the delineate, like if you're looking at the if we show the colon, where are we? Let's show the colon here. which is quite difficult in this case. But if you've got your transverse colon coming out here at the front, you know that this is going to be the transverse colon. However, if you're kind of getting into this territory around the splenic flexure and around the hepatic flexure, it can be somewhat difficult to kind of differentiate what is ascending versus hepatic versus transverse colon, hepatic flexure versus transverse colon. So in that situation, there's a degree of interpretation and that would then dictate what the vessel is called. So the middle colics, by definition, are the vessels supplying or draining the transverse colon, but given the degree for open interpretation as to what would be transverse colon versus splenic flexure versus descending colon, you could easily call this an accessory left colic artery as well. But given the common trunk in this case, as in you have this vessel which is emerging from this middle colic artery, this is likely going to be the left branch of the middle colic artery, as opposed to an accessory left colic artery, which you would define as a vessel that would be supplying the descending colon. And if you can follow these out, these eventually will kind of join up to be all one continuous circuit. But I wouldn't. It's not going to be that clinically relevant, and it's certainly not if you've got a CME surgeon. It's not necessarily going to be anything they're that interested in. So it's just more of a point of anatomical interest, as opposed to something which is going to be detrimental to the case. I think there's probably. I don't know if you can kind of. You can see. I don't know if you can see. There's just like a kind of a little flash of something moving horizontally here, which I suspect will be a anterior pancreatoduodenal vessel. And you can see here, there's a little flash of something that's kind of, if you follow it back, it's going to the gastroduodenal artery. So this will likely be a pancreatic duodenal artery, as opposed to anything that we want to segment for our case that would be relevant. So I think we can kind of be confident there's maybe something coming into the SMV here. I think the difficulty maybe in this case that I'm struggling with is whether you'll notice that you've got this bifurcation of what I think is MCV. So the common trunk is here, and then it bifurcates into two vessels, one accompanying this distal branch of the right MCA rather, and one accompanying this this other terminal branch of the right MCA. So I think the difficulty is that in this case, I think you've probably got a GEV and an ASPDV. The question would be whether this vessel under here is originating from the trunk of Henle proximally, or whether this is just an overlying vessel. And because the scan itself is a little bit tricky in terms of the contrast between these structures. That is quite tricky, and they do kind of blend. But I think on balance, I think this is I think it is probably coming from the middle colic rather than Henle's, and I think it's probably a middle colic vessel as opposed to say coming off the anterior aspect of Henle. But I probably will get a second pair of eyeballs on that to corroborate my my interpretation, because it's this area. If you take away the opacity of the labels, it's very difficult to kind of see. But maybe it is coming from Henle. I think in these situations it's often best to have a break from looking at it and come back to it with a bit more of a fresh eye. So we'll just now move towards segmenting the colon, duodenum and pancreas and then come back to this with a bit more of a kind of a fresh eye, because you just start to get a bit cross-eyed looking at the same thing, especially if it's difficult, and you'll kind of look at it, change your mind, look at it again, and then change your mind back, and you can kind of get a little bit stuck. So it's best in that situation just to kind of have a break.